Good evening, dear students. I welcome you back in the third day of FMGE marathon session. Again, we are starting at 6 in the evening and we'll try to wind up by 7:30, 1.5 hour session. What we are going to do today is take care of the abdomen region and pelvis perineum, then the lower limb. Again, focusing upon some of the topics which are important topics in the view that they might be asked in the next coming exam. It is kind of a repeat information, kind of a revision, but the more we revise, the less we forget and less we make mistakes. Let me just go through the chat as well. Dr. Jacob, good evening. Yes, Kaushal Suman, good evening. Gaurav Sharma, Lokendra, Putin, Ram sir, Ram. Okay, so Yakshi, AK-47, Alishknov, Yugandhar, Bobby, Yashraj Parmar, Virat, Dr. Lit, Hari. Welcome you all and let us continue. Good evening to you all. Yes. So, what you are looking at is the lateral view of a developing baby, and what we want to do is look inside the content of the spinal cord. Then we will be talking about anterior abdominal wall defects. Questions are coming like omphalocele, gastroschisis, the Meckel's diverticulum, even the ectopia vesicae has been one new question. So, trying to discuss the anterior abdominal wall defect, but before that you should have some embryological concepts clear. This is a schematic diagram and we have to understand, like I'll start here mentioning. In the beginning, there will be a yolk sac which you see here, and this yolk sac is lined by endoderm. It is the yolk sac which is lined by endoderm will give us the gut tube also. It squeezes and converts itself into gut tube. The gut tube which you find here will have a foregut portion, a midgut portion and a hindgut portion. So, it is the endoderm of the yolk sac which will give us the gut tube. Gut tube itself will have foregut, midgut and hindgut. The midgut, as I will magnify it a bit here, will be continuing to get attached with the yolk sac, as is evident here. Yolk sac is attaching, let me take some other color, maybe red. So, this is the yolk sac which is continually connected with the midgut, and that connection is called as vitalo-intestinal duct. Some books will call it as omphalomescentric duct. So, omphalomescentric duct or vitalo-intestinal duct is the connection of the yolk sac with the midgut, and it is becoming a content of the umbilical cord. Here is the umbilical cord. So, as we are mentioning, this umbilical cord will have some of the contents, and one of the content is vitalo-intestinal duct. Normally, it should obliterate, but sometime if it is persisting, there can be problem like Meckel's anomaly. The other thing which you notice is during development, the gut tube was developing faster and the abdominal cavity was smaller. So, for some time the midgut will herniate inside the umbilical cord, which is called as physiological umbilical hernia, and that midgut herniation into the umbilical cord, which is called physiological umbilical hernia, is happening at week number 6 of intrauterine life. So, at week number 6 of intrauterine life, we found that gut was developing fast, abdominal cavity is comparatively small. So, part of the midgut will herniate inside the umbilical cord. That is week number 6. Week number 10 to 11, it will go back. So, week 6 it comes, and week 10 to 11, there will be a regression of physiological umbilical hernia. The midgut will go back into abdominal cavity because now abdominal cavity is large enough to accommodate the developing gut. In some people, in some babies, there will be non-regression of physiological umbilical hernia. It doesn't go back, and it is called omphalocele. So why do we get omphalocele? We are getting the problem which is called as omphalocele because of non-regression of the physiological umbilical hernia. The baby is born with the umbilical cord containing the derivatives of the gut tube, even the liver. Liver may be inside the umbilical cord. Omphalocele. We'll talk more about that. It is also one of the anterior abdominal wall defect. One other thing which you notice is the hindgut is sending one diverticulum, which we can mark here. The allantois. Let me take some other color, maybe white. So this is the allantois, and what is allantois? Allantois is a hindgut diverticulum, which is again becoming a content of the umbilical cord, and surrounding the allantois you will have two umbilical arteries, two umbilical veins. So two umbilical arteries, two umbilical veins, they are surrounding the allantois, they are all content of the umbilical cord. We will take a transverse section of umbilical cord and talk about a jelly also, which is called as Wharton's jelly. So there will be a Wharton's jelly inside which you will have the allantois, the vitalointestinal duct, and then some of the blood vessels. But let us first draw this diagram ourselves to discuss one more anomaly, which is the allantoic anomaly. Normally what happens is this allantois, which has lumen and is a hindgut diverticulum, should be obliterated and become urachus. Urachus has no lumen. In some babies, urachus may have lumen. You will say urachal fistula. And urachal fistula is actually continuous with the urinary bladder in the newborn baby. So you might find a baby born with anterior abdominal wall defect and urine coming out of the umbilicus because of that urachal fistula. The other baby, you may find that fecal matter is coming out of umbilicus due to Meckel's anomaly, Meckel's fistula. So let us discuss this again by drawing a diagram ourselves. It will be the similar type of diagram which we have just seen. Say, we are looking from the lateral view, again a developing baby, and mentioning that this is the gut tube, and this gut tube is actually lined by endoderm. It is derived from the yolk sac. This is the yolk sac, and it is the yolk sac which will give us the gut tube lined by endoderm, and the gut tube will have three parts. As we mentioned, there will be a foregut, there is a midgut, and then there is the hindgut. Now it is also understood that it is the midgut which is continuous with the yolk sac, and this communication, which is called as vitalointestinal duct, is actually passing through the anterior abdominal wall through the umbilicus and becoming a content of umbilical cord. So midgut is communicating with the yolk sac with the help of vitalointestinal duct, which is actually passing through the umbilicus, which is on the anterior abdominal wall, and passing through the umbilicus, it becomes a content of the umbilical cord. Normally it must be obliterated, and if it is not obliterated, then there can be problems which we are calling as Meckel's anomalies. Meckel's anomalies are due to abnormal persistence of vitalointestinal duct. Now there is one more diverticulum which is passing through umbilicus, becoming a content of the umbilical cord, that is allantois. To discuss allantois, first we go to hindgut. In the hindgut there is a cloaca region. The terminal part of the hindgut will have a cloaca region. In the cloaca region of the hindgut, you will find a septum which is called as urorectal septum. It is called urorectal septum because, let us magnify this a bit. It is called as urorectal septum because it is dividing the hindgut into two portions. Anteriorly develops the urogenital sinus and posteriorly develops the rectum. That is why the name is urorectal septum, dividing the cloaca region of hindgut into two portions. One is urogenital sinus anterior and rectum posterior, urorectal septum. It is the urogenital sinus which will give us a lot of derivatives. One of that is urinary bladder. So urogenital sinus will form the urinary bladder, and once we have that much of information, we find there is one hindgut diverticulum which we are going to show now. Let us use some other color, this color. There is a hindgut diverticulum which is called as allantois, and this allantois, which is hindgut diverticulum, is having some lumen. It is passing through umbilicus and becoming a content of umbilical cord during development, but it must be obliterated. The lumen must be lost and must change normally into what is called as the urachus. So normally we will see there is a structure called urachus. It should be fibrous, it should have no lumen. Some babies, it might have lumen leading to urachal fistula. And if there is a urachal fistula, you will find the urinary bladder, apex of urinary bladder. From the apex of urinary bladder, some urine keep coming out through the umbilicus of a newborn baby. A baby born at birth, urine coming from umbilicus is coming from the apex of urinary bladder and is a problem of urachus. It is called urachal fistula. On the other hand, there was another baby born with fecal matter coming out at the umbilicus. Maybe it was a Meckel's fistula attaching to terminal ileum, part of the midgut. So terminal ileum, part of the midgut, some fecal matter coming out through the Meckel fistula to the umbilicus. These are all anterior abdominal wall defects. Let us do one thing. We will take a transverse section of the umbilical cord now and look inside the content of the umbilical cord, and we will draw it. But before we draw that diagram, you can just have an overview that what if we are taking a transverse section of the umbilical cord, what do we see there? Say, first of all, umbilical cord will be covered by what is called as the amnion. There is a covering of amnion, and inside the umbilical cord will have a jelly which is called as Wharton's jelly. Inside the Wharton's jelly will have the midgut for some time, for a month time, and one diverticulum also which is called as vitalointestinal duct. So midgut as well as the vitalointestinal duct, but they should regress and they should be obliterated normally. What else do you find is allantois, which should be obliterated later, a hindgut diverticulum, and along with the allantois, it is actually surrounded by two umbilical arteries and two umbilical veins. Veins we are showing in red color because in fetal circulation, veins carry oxygenated blood from mother placenta to the baby. So veins are red because they carry oxygenated blood, and arteries are blue because they carry deoxygenated blood from the baby towards the placenta, towards the mother. Now we have in the beginning two umbilical veins and two umbilical arteries, but later one umbilical vein will disappear, only one will be remaining. So we draw the same diagram and discuss some of the anterior abdominal wall defects now. And as we do, we are telling this is a transverse. This is a transverse section of the umbilical cord which is covered by amnion, and it is having a jelly called as Wharton's jelly. And what is there in the Wharton's jelly? We mentioned that for some time at week number 6 midgut will come, and week number 10, 11 it should go back, physiological umbilical hernia. So we are showing that it will have a midgut, and connected with the midgut will be a vitalointestinal duct also. So not only midgut but also vitalointestinal duct, they are content of the umbilical cord. Normally midgut should regress and vitalointestinal duct should be obliterated. So what will happen if there is non-regression of physiological umbilical hernia? In that case, you will find baby born with the midgut derivatives inside the umbilical cord, what is called as omphalocele. So omphalo means umbilicus, cele means hernia, it is kind of umbilical hernia. We will find a photograph also which the examiner gives you to identify which kind of anomaly is this. But non-regression of physiological umbilical hernia can result in omphalocele. What will happen if there is non-obliteration of the vital interstitial duct? If there is non-obliteration of vital interstitial duct, the other problem which is Meckel's anomaly. So it could be Meckel's cyst, or it could be Meckel's duct, Meckel's diverticulum, or it could be Meckel fistula also. Baby born with fecal matter coming out at umbilicus because there is a Meckel fistula. Talking about the other content of the umbilical cord, there was something called as allantois. And allantois is a hindgut diverticulum. Normally it should be obliterated to become urachus. What if urachus is having a patency of lumen? That will be a problem. And you will find it is called as the urachal fistula. So urachal fistula is just the urachus having a lumen and bringing some urine from the apex of urinary bladder to the umbilicus. It is again anterior abdominal wall defect. Normally allantois is surrounded by say 2 umbilical arteries and 2 umbilical veins. So these are the 2 umbilical arteries and 2 umbilical veins. We are showing the veins in red color because in fetal circulation veins carry oxygenated blood. Arteries, they are carrying the oxygenated blood. Now there are 4 of them surrounding the allantois, but later we find that the right umbilical vein regresses RR and left is left LL. Means during development, right umbilical vein regresses and left umbilical vein is left. RR, right regresses, LL, left is left. Now, wherever the right umbilical vein was regressing, a weak spot was created. And in some babies, in some of the babies, you may find that through that weak spot, some intestine is coming out. There is an intestinal herniation called as gastroschisis. So, what is gastroschisis? Gastroschisis is intestinal herniation at a weak spot created by regressing right umbilical vein. That is why gastroschisis you find will be on the right side of umbilicus in clinical scenario. Plus one more thing, this intestine is coming out of the amnion. It will not be covered by amnion. As compared with omphalocele, in omphalocele the intestinal herniation is covered by amnion. This will become more evident in the photographs which we are going to look at now. So as we proceed further to talk about those babies, these are the 4 babies which the examiner is giving you persistently, consistently, continuously, repeat questions. And the problem is that despite knowing that these are the questions which come to us very frequently, we answer them wrong. Why we answer them wrong? Knowing a thing and answering it wrong is called blunder. Why do we make blunders? We make blunders because maybe we are overconfident that we already know it. So we are not going to make a mistake, but we do make mistake in the exam. So how to avoid the blunder? To revise it, and that's what we are doing it. We continuously keep revising to minimize our mistakes, to minimize our blunders. Second thing is that maybe you know these are the topics which are coming and maybe you have read adequately, but the examiner knows that you have read it adequately, so he'll dig a bit down, deeper. So not only we have to actually master the topic, but we have to go around the topic a little bit wider than the question which were asked previously. Means the depth of our knowledge should keep on increasing. If you find a question, a topic is repetitively asked, because next time the examiner will be 2 steps ahead. And that's what we do, that's what we teach, that's what you learn, and that's what you should remember also. Anyways, now if you are given this kind of a diagram, you will find that the surgeon has already removed the intestine outside, and there is something here which they will put a marker, and just to train your eyes on these 4 patients. That will be Meckel's diverticulum. Now if you say this is the Meckel's diverticulum, First of all, you should be able to identify how it looks like. Like it will be 2 to 3 inches long, though there is a rule of 2, but it can be 2 to 3 inches long. It is at the terminal ileum near the ileocecal junction. The rule of 2 says it is 2 inches long, 2 feet away from the ileocecal junction. All those things you should know, and you should also know that it is a true diverticulum because it will have all the 4 layers of the gut tube: mucosa, submucosa, muscular layer, serosa. So it is a true diverticulum because it has all the 4 layers, and a lot of other things which you will find you continuously revise. Here the purpose is just to mention that it was abnormal persistence of the vitellointestinal duct that resulted in McCall's diverticulum. Now what about this case? It is one case which you find that a baby is born and some of the content of the abdominal cavity are projecting through the umbilical region. Umbilical hernia, which can be congenital in some cases, and it happens because there is some weakness of the muscles in the midline. And it is not a very big deal. You can just push it back and seal the defect. But it can come as one of the diagram or as one of the option in the question, umbilical hernia, congenital umbilical hernia. Then you might have this diagram here, as I'll magnify. These two are consistently asked and compared. So both are anterior abdominal wall defect. Here you find that some part of intestine has come out of the anterior abdominal wall to the right side of umbilicus, and umbilical cord is normal. So umbilical cord is normal, first of all. Second, intestinal herniation on the right side of the umbilicus. Third, it is not covered by amnion. Gastroschisis. Why do we have gastroschisis? It is intestinal herniation at a weak spot created by normally regressing right umbilical vein. That is why it is to the right side of the umbilicus. Compare it with the omphalocele. Omphalo means umbilicus again, cele means hernia, umbilical hernia. So why do we get omphalocele? Why do we have liver and midgut derivatives inside the umbilical cord covered by amnion? Omphalocele, the contents are covered by amnion. Gastroschisis, contents are not covered by amnion. In gastroschisis, the umbilical cord is on one side and is normal, but in omphalocele, umbilical cord is not normal. It is actually containing some of the derivatives, like you can see large portion of liver here. But why this happened? Why omphalocele? Non-regression of physiological umbilical hernia. Normally midgut comes into umbilical cord and goes back after some time. If it doesn't go back, non-regression of physiological umbilical hernia, omphalocele. And these babies are mostly dead babies. Why? Because they not only have GI defect, they also have chromosomal abnormality, cardiovascular defect, neural tube defect that kill the baby. Multiple congenital anomalies. GI defect, chromosomal defect, neural tube defect, cardiovascular defect, they are going to die even if they were alive at birth. So they don't survive much as compared with the gastroschisis. They do survive, they are healthy babies. Only problem they might face is that because the intestine is outside, they have a long mesentery, and because of that there can be volvulus or intestinal obstructions, and babies might keep coming back to you with intestinal obstruction. That is the only problem gastroschisis babies will have. Otherwise they are healthy babies compared with omphalocele. So this is some information which you wanted to talk about. Now, moving further, there are questions which are asked to you on this topic also, which is mesentery. Let me just go through the chat. Okay. Brainstem lesion, spinal cord related syndrome. It's a topic itself, 1.5 hour long. Cardiac defect, yes. CVS mortality, omphalocele, right. Okay. 2% population, yeah, rule of 2. Right. I think we are on track. You are quite well answering the details before I write. You already have mentioned. So it is kind of a revision. Yes, of course. Now, very repetitively asked question about the mesentery. What is a mesentery? Mesentery is double fold of peritoneum to carry some neurovascular bundle like the artery, the vein, the nerve, the duct. So mesentery is double fold of peritoneum to carry some neurovascular bundle. Normally what we see is when we take a section of the gut tube, section in the abdomen region, there is a peritoneum which is covering the abdominal wall in the periphery, which is called parietal peritoneum, and there is a peritoneum which is covering the viscera, which is called visceral peritoneum. So if you cover the viscera, it is visceral peritoneum. If you cover the body wall, say posterior abdominal wall, lateral abdominal wall, anterior abdominal wall, that is parietal peritoneum. Between the parietal peritoneum and the visceral peritoneum, you will have peritoneal cavity. If you are talking about the gut tube, it is the axis, and there is some peritoneum in front of that, some peritoneum behind that. The double fold of peritoneum which is in front of the axis or the gut tube is called ventral mesentery, and the double fold of peritoneum which is developing behind the gut tube is called dorsal mesentery. So there will be a dorsal mesentery, ventral mesentery. This is going to be anterior abdominal wall, like you see here, anterior abdominal wall, and there will be posterior abdominal wall. On the posterior abdominal wall, you can talk about the abdominal aorta. Abdominal aorta will be lying on the posterior abdominal wall, giving some branches like branches to the foregut, midgut and hindgut, and those branches will be carried by double fold of peritoneum, the mesentery. Now that is the posterior abdominal wall having abdominal aorta as shown here, and on the anterior abdominal wall, like earlier when the baby is developing, placenta will be sending left umbilical vein, and to carry the left umbilical vein from the placenta through the umbilicus will be a channel that is basically ventral mesentery forming some ligaments. One other thing which you can see is this is foregut, midgut and hindgut. The midgut is herniating outside the umbilicus. We called it as physiological umbilical hernia happening at week number 6, but week number 10 it should go back. If it is not going back, you can have a case of omphalocele. Now what is the artery for the foregut? Artery for the foregut is celiac artery, branch of abdominal aorta, which is given anterior. So these branches are anterior branches coming from the abdominal aorta. For the foregut it is celiac artery, for the midgut it is superior mesenteric artery, and for the hindgut it is inferior mesenteric artery. Now how do you send this celiac trunk or superior mesenteric, inferior mesenteric artery to reach the foregut, midgut and the hindgut? Carried by double fold of peritoneum, which is called mesentery. Since it is behind the gut tube, you will call it as dorsal mesentery. Now why it is written as mesogastrium? Because it is in relation to the stomach. If it is in relation to stomach, gastrium. If it is in relation with the esophagus, then you can call it as dorsal mesoesophagus. If it is duodenum, dorsal mesoduodenum. If it is colon, mesocolon. Mesocolon, mesoduodenum, mesogastrium, mesoesophagus, mesoterm, and whatever the viscera you are talking in terms of. Now, dorsal to the stomach develops some mesenchymal condensation called as spleen. So spleen is coming from mesoderm. There is a mesodermal condensation in the dorsal mesentery. And then you have to talk about abdominal aorta giving splenic artery to spleen will be carried by dorsal mesentery, developing into a ligament, and you have to talk about the name of ligament. Similarly, some blood vessels will be running between spleen and the stomach, carried by some ligament. We have to name that ligament. If you look in front of the stomach, there is the lever developing in the ventral mesentery, and some ligaments relate with the lever to the anterior abdominal wall to the stomach. So anterior and posterior we have to name those ligaments and their contents because continuously asked questions. Also remember that in the beginning the stomach lesser curvature is anterior and greater curvature is posterior. With that overview, let us draw the same diagram, little bit modified, and talk about the ligaments developing in the dorsal mesentery and ligaments developing in the ventral mesentery. That diagram is also going to show the diaphragm because this is abdomen below diaphragm, and we are basically talking about the details of abdominal aorta also giving branches carried by double fold of peritoneum, the mesentery. So let's draw that diagram. As we do that, say we are looking from the side view, and we are telling the anterior abdominal wall, umbilicus, posterior abdominal wall, abdominal aorta, diaphragm separating thorax from the abdomen from the side view. As we draw it, this is, let us say, umbilicus on the anterior abdominal wall, and then you can also show the posterior abdominal wall, and on the posterior abdominal wall we can talk about the abdominal aorta. So this is the abdominal aorta which is on the posterior abdominal wall giving some branches to the gut tube and other viscera. Then we can also show the diaphragm. Here is the diaphragm which you can call as thoraco-abdominal diaphragm because it is separating thorax above and abdomen below. Thoraco-abdominal diaphragm. And in the abdomen you can focus upon the gut tube. Say this is the gut tube. The gut tube will be modified into certain components which we can name. This is foregut, and in the foregut you can tell piercing through the diaphragm is a small part of esophagus as a content of abdomen. Esophagus continue as the stomach continue as the duodenum. These are parts of the foregut we are looking at: esophagus, stomach and duodenum. Stomach also we mentioned anteriorly will be the lesser curvature in the beginning, and posteriorly will be the greater curvature. Later there is some rotation of the gut tube, but before the rotation lesser curvature is anterior, greater curvature is posterior. And these viscera, they are covered by a double fold of peritoneum which is visceral peritoneum. But this peritoneum, when it is not covering viscera, running from anterior abdominal wall towards the posterior abdominal wall will be a double fold of peritoneum called as mesentery. So as we show the mesentery now, let us use this color. There is a fold of peritoneum, double fold of peritoneum, which is running anterior to posterior from anterior abdominal wall towards the posterior abdominal wall, making ventral mesentery and dorsal mesentery. What exactly is this mesentery? Double fold of peritoneum which is running from anterior abdominal wall, splitting to enclose the viscera and continue running towards the posterior abdominal wall and carrying some of the nerve, artery, vein, ducts, etc. like that. So which structures they are carrying? We have to find out. And in the adult, what is their modification? Because some ligaments will develop here. Before you start discussing those ligaments, we should know kidney develops in the pelvis, later ascend into the abdomen. So kidneys develop in the pelvis, later ascend into abdomen, can also be shown here. Say for example, this is the kidney now which was developing in the pelvis, and later it is ascending up to reach the abdomen region. So this is the kidney in the abdomen. When the kidneys which were developing in the pelvis, they ascend up into the abdomen, they remain retroperitoneal, behind the peritoneum. Like abdominal aorta is also retroperitoneal. So may it be the abdominal aorta or kidney, they remain retroperitoneal or behind the peritoneum. Then what is intraperitoneal? The gut tube and some other viscera, like one of the viscera which we talked about. Say there was a mesenchymal condensation in the dorsal mesentery. So in the dorsal mesentery there was some mesenchymal condensation and forming spleen. Spleen is mesodermal in origin. And in relation to that spleen which develop in the dorsal mesentery, you'll have some ligaments. Like there's a ligament which is between spleen and kidney, very simply called as splenorenal ligament. So there'll be a splenorenal ligament which is between spleen and kidney, and this ligament is carrying one artery to spleen. The artery which is given by abdominal aorta, and this artery, the splenic artery, is carried by the ligament. So here we are showing this is the splenic artery which is carried by splenorenal ligament. Once again I'll repeat, between spleen and kidney you have a ligament simply called splenorenal ligament, or it is also called as linorenal ligament. So linorenal or splenorenal ligament, what does it carry? Some neurovascular bundle. For example, aorta, abdominal aorta giving the artery, splenic artery to spleen will be carried by the splenorenal ligament. Now this artery, splenic artery, itself is giving branches, say it is giving us what is called as the short gastric arteries to the greater curvature of stomach. Now these short gastric arteries, which are branches of the splenic artery, the splenic artery giving short gastric artery to supply the greater curvature of stomach, will be carried by which ligament? The ligament which develop between greater curvature of stomach and the spleen. And what is the name of this ligament? The name of this ligament will be accordingly gastrosplenic ligament. Stomach, spleen, gastrosplenic ligament. So gastrosplenic ligament which attaches greater curvature of stomach to the spleen carry what? It carries some neurovascular bundle. One of the artery it carry is short gastric artery, branch of splenic artery, which itself is a branch of abdominal aorta. Now you can come, here you are mentioning the dorsal mesentery giving two ligaments, the two ligaments related with spleen. So dorsal mesentery is developing two ligaments related with spleen. You can call them as splenorenal or splenogastric. On the other hand, if you talk about the ventral mesentery, you can again see some ligaments developing. One of the organ which develops here is the liver. So where is liver developing from? Liver is the endodermal derivative of the foregut. Liver develops from endoderm of the foregut, and liver is developing inside the ventral mesentery. The ventral mesentery itself now modifying into some ligaments, like you will find one of the ligament which we can use some other color, maybe green color, is between the liver and the lesser curvature of stomach. So this ligament which is between the porta hepatis of the liver, porta hepatis where some of the structures enter and leave the liver, the ligament which is attaching the porta hepatis of liver with the lesser curvature of stomach is called as hepatogastric ligament. It is evident the name is given according to the structure being attached. So porta hepatis of liver to the lesser curvature of stomach, hepatogastric ligament. And then there is some portion which attaches to first part of duodenum, and that obviously will be called as hepatoduodenal ligament. Hepatoduodenal ligament. So where is hepatoduodenal ligament attaching? To liver and the first part of duodenum. Together, hepatoduodenal ligament and hepatogastric ligament are called as lesser omentum attaching to lesser curvature. So when you say there is something called as lesser omentum, it will have two parts. What are the two parts of lesser omentum? Lesser omentum attaching to lesser curvature is a double fold of peritoneum, having two components, hepatogastric ligament, hepatoduodenal ligament. And in the lesser omentum, you will find that there are some structures which are called as DAV structures entering or leaving the porta hepatis of liver, passing through the hepatoduodenal ligament, part of lesser omentum. I will repeat again. In the liver porta hepatis, there is DAV structure, either leaving or entering the liver, and they are carried by hepatoduodenal ligament part of lesser omentum. What is this D? D is the duct, the bile duct. A is the artery, hepatic artery. V is the vein, portal vein. So D is the duct, the bile duct. A is the artery, hepatic artery. V is the vein, portal vein. Where are they? They are either entering or leaving the liver at porta hepatis and carried by hepatoduodenal ligament, part of the lesser omentum. Don't mention that DAV structure will be carried by hepatogastric ligament. It is not hepatogastric ligament. It is the hepatoduodenal ligament, part of lesser omentum. Lesser omentum has two parts. So as I mentioned, like earlier we used to teach some details, now we are adding further details and you have to be very specific in answering them. What is the name of ligament which is attaching now liver to the anterior abdominal wall? This ligament which attaches liver to the anterior abdominal wall is also developing in the ventral mesentery, is called as falciform ligament of liver. And what is this falciform ligament of liver carrying? What is the content of falciform ligament of liver? So first of all, may it be falciform ligament of liver or lesser omentum, they were attaching to liver. Lesser omentum or falciform ligament of liver, they attach to liver and they are both developing in ventral mesentery. What is the content of falciform ligament of liver? During development, as we have learnt earlier, there will be a structure called as placenta, and placenta will be sending a vein through the umbilicus into the liver called as left umbilical vein, and that left umbilical vein is carried by falciform ligament of liver. Once again, during fetal development, there is placenta sending oxygenated blood towards the baby via a vein called as left umbilical vein, and left umbilical vein carry the oxygenated blood from placenta. The vein passes through umbilicus, passes through falciform ligament of liver to reach the liver. When the baby is born, what you do is you have to remove the placenta. And as you remove the placenta, you cut the left umbilical vein, but you cannot remove left umbilical vein in entirety because this part of left umbilical vein will always persist in the adults. So the baby is born now, you have to remove the placenta as the baby is born. You will cut the left umbilical vein. Part of that vein can be cut, but some part will always be remaining inside the adult. And that part of left umbilical vein is called as ligamentum teres. So this is the ligamentum teres, and ligamentum teres is the adult remnant of. The ligamentum teres is the adult remnant of left umbilical vein, which you cannot remove. Keep connecting the umbilicus to the liver is the content of falciform ligament of liver. So these are some of the questions, frequently asked questions, which you should keep revising. Maybe whatever I told you, you already know it. Then what is the purpose of this session? It is just to revise at least once again, because if we don't revise, problem will be we will make blunders, and it is very painful. No, blunder is a painful thing because despite the fact that I knew the answer, but I could not answer it in the exam hall. It's very painful for a teacher who taught, and despite that you made a mistake in the exam hall. And for you, of course, it is painful because you have to write the exam again. Nobody should write any exam again, isn't it? With that view, we are going to look at this diagram also, which is what we have already drawn, and it is kind of a revision again. Same diagram we have drawn. We have discussed spleen develop in dorsal mesentery, liver develop in ventral mesentery. In the dorsal mesentery, there are some ligaments developing. We already have named some of them. Let me capture them once again. As we were talking about the derivatives of dorsal mesentery, we already have mentioned the names like lienorenal ligament or splenorenal ligament. Then we have talked about the gastrosplenic ligament. Now you see some more derivatives which you have to memorize. If the ligament is attaching to greater curvature of stomach, which is posterior in the beginning, and to the diaphragm, the name is accordingly stomach and diaphragm. So gastrophrenic ligament is also developing in the dorsal mesentery. So what you see here, as you will notice, this is greater curvature of stomach and the diaphragm. The ligament is accordingly called gastrophrenic ligament, developing in dorsal mesentery. What else? You will find that there is a double fold of peritoneum which is just hanging from the greater curvature of stomach. And that double fold of peritoneum which is developing in the dorsal mesentery, hanging from the greater curvature of stomach, is called as greater omentum. So even greater omentum attaching to greater curvature, a double fold of peritoneum, develop in the dorsal mesentery. Remember these four derivatives of the dorsal mesentery. And what about the ventral mesentery? In the ventral mesentery, we have named some ligaments, like already we talked about the falciform ligament of lever and the lesser omentum. Lesser omentum having two parts. What are the two parts of lesser omentum? One which attaches to the lesser curvature of stomach, hepatogastric, and one which attaches to the first part of duodenum, which is hepatoduodenal. Hepatoduodenal ligament, part of lesser omentum, is also called as free margin of lesser omentum. Lesser omentum will have two components: hepatogastric ligament, hepatoduodenal ligament. Hepatoduodenal ligament, part of lesser omentum, is also called as free margin of lesser omentum. And it is this free margin of lesser omentum which will have DAV structure. D for duct, bile duct, as shown here, this green color. A for artery, hepatic artery. V for vein, portal vein. So DAV structures carried by free margin of lesser omentum, which is also called as hepatoduodenal ligament, developing in ventral mesentery. In ventral mesentery, you will find a part of the pancreas is also developing, which is a small part of the head of pancreas and uncinate process of pancreas. So small part of the head of pancreas, uncinate process of pancreas also develop in ventral mesentery. Later migrate to dorsal mesentery. This question can come. Pancreas majorly develop in the dorsal mesentery, but part of it develop in ventral mesentery. Which part of pancreas develop in ventral mesentery? A small part of the head of pancreas and uncinate process develop in ventral mesentery, later migrate to dorsal mesentery. And what else was developing in the ventral mesentery? Attaching lever to the anterior abdominal wall. That was the falciform ligament of lever, carrying this vein also. As you see, this vein is the left umbilical vein, passing through umbilicus and going to lever. So a remnant of the left umbilical vein attaching umbilicus on the anterior abdominal wall to the lever is ligamentum teres. Ligamentum teres is a content of falciform ligament of lever. You should also remember some other names for ventral mesentery derivatives, as you see here: triangular ligaments, coronary ligaments. So where is this triangular and coronary ligaments attaching? They attach to lever. Where do they develop? In the ventral mesentery. But what exactly is their relation? The triangular ligaments and coronary ligaments are also developing in the ventral mesentery like the falciform ligament of lever, but they attach lever to the anterior abdominal wall and the diaphragm, anteriorly and superiorly. So when you attach lever to the anterior abdominal wall and diaphragm, anteriorly and superiorly, they'll have some different names. More superior, it is triangular ligament, and if it is actually coronary ligament continuously to be called as triangular ligament. So this area is coronary and triangular ligament. More posteriorly, it will change the name, called as lesser omentum. More anteriorly, inferiorly, it will change the name to be called as falciform ligament. But they are all developing in the ventral mesentery. I hope that will help you a lot, because I am expecting that this question, the derivatives of mesentery, will definitely be one of the question coming in your latest upcoming exam. That's what we are trying to do here, talk about some of the topics which are high-yield topics and might appear in the recent coming exam. So, okay, right. Your hair grows a lot, sir. Where is the hair? All the hair is going off now. Okay. Right, fantastic. I think the same story. You all are hardworking people. You already have all the information. My job is just to, brush up all the important topics quickly so that you don't make mistakes. We are humans. We are bound to make mistake. So what to do? Minimize making mistakes. And how do I minimize making mistakes? Working hard, revising it again and again, and trying to learn things in more depth, little bit more depth, because eventually you are going to become a physician, a surgeon, and you will have, means human life is in your hands, and you cannot be casual, you should actually leave no stone unturned to make sure that your information, your knowledge is perfect, and there is no ending to learning. Yes, of course, you will get the PDF, no doubt. 3 days are over. I will convert this OneNote into PDF file, annotated PDF file, and that will be link given to PrepLadder. And they already are mentioning like some Telegram channel is there. From there you can download the PDF, no issues. How many questions can we expect from an anatomy marathon, sir? 10 questions at least, can be 20 also. See, do you notice that I don't only teach you anatomy, I teach you anatomy plus physiology, plus surgery, plus ENT, plus ophtha, plus radiology. So, maybe in anatomy you will get 10 questions from what we are discussing here, but if you see overall, it might be 20 questions, maybe more than 20. Let us just be hopeful. But I will advise that there are other faculties who are coming, teaching you physiology, biochemistry, surgery, pathology, ENT, all the 19 faculties, this FMGE marathon, if you go through all the videos, I am very sure 80% questions will come from here. 80% questions in your next coming exam will come from the sessions which are going here. That much I have the confidence. Now maybe, sometimes we are we become much hopeful, but even if it is 80% becomes 70, what is your target? Just to cross the barrier of 50%, isn't it? So my advice, just religiously go through these sessions. That will be very helpful. Okay, so my job is to boost your confidence, and that confidence should be boosted by giving you solid data which is based upon our experience and our instincts. We work upon both. According to our experience, we will work upon the topics, and according to our instinct, we will tell you that might be these topics which will be reappearing in your exam. Okay, right, let us continue. If you have gone through the previous year questions, you will find there are some planes they will always keep asking. So let us talk about them. In this diagram, you will notice that we are, say, talking about some planes in the abdomen region, and very important among that is transpyloric plane. So let me just keep it in the middle. The transpyloric plane, which is also called as Addison's plane. Now, as the name is suggesting, transpyloric plane, it will pass through the pylorus of the stomach, where the stomach becomes duodenum. Stomach becomes duodenum at the pyloric region, so transpyloric plane. If you go posterior, you will find that there is L1 vertebra lower border. So, lower border of L1 vertebra. As you see, this is the L1 vertebra. This is L1 vertebra, lower border of L1 vertebra, that is where you have transpyloric plane, which is also called Addison's plane. At this plane only, there is termination of adult spinal cord. Adult spinal cord will be terminating at L1 lower border, transpyloric plane. That is the plane where you will be doing the Murphy sign. Murphy sign. What is Murphy sign? Murphy sign is you keep your fingers at the tip of costal cartilage number 9 in the mid clavicular line. This is the clavicle. Go to the mid of clavicle, put a line down. A line will come like this, mid clavicular line. Go to the middle of the clavicle, put a line here, mid clavicular line, and reach the tip of costal cartilage number 9. You count the ribs, go to the 9th rib, tip of 9th costal cartilage. So tip of the 9th costal cartilage, mid clavicular line, transpyloric plane, that is where you put your fingers, and you are suspecting a case of acute cholecystitis. Acute cholecystitis. Now, you'll ask the patient to take a deep breath. Take a deep breath. As the patient will take a deep breath, diaphragm descend down. Push the lever gallbladder down, and the gallbladder touches your finger, and the patient will wince due to pain, because now the fundus of gallbladder touches your fingers. I'll repeat again. If you are suspecting a case of acute cholecystitis, gallbladder inflammation, you are going to do this test, which is called Murphy sign. Take your fingers at the tip of costal cartilage 9 in mid, it is transpyloric plane, mid clavicular line. Ask the patient to take a deep breath. When you take a deep breath, in deep inspiration, diaphragm descend down, pushing the lever gallbladder down, and as the gallbladder touches your finger, there will be pain. You can see, look at the face of the patient, there will be an expression of feeling pain, and that is a positive sign that maybe this patient has a problem of acute cholecystitis. Then you do ultrasound, and then you deal with the case. What else happens at L1 lower border, transpyloric plane? You'll find that the hilum of each kidney, may it be the right kidney or left kidney, the hilum where you have renal artery entering from the abdominal aorta. So abdominal aorta will give renal artery. So both the renal arteries enter the hilum of kidney, maybe right kidney, left kidney, at which plane? Transpyloric plane, L1 vertebra lower border. So L1 vertebra lower border, there are a lot of things happening. One is you find pylorus of stomach there. Other is hilum of each kidney there. Other is termination of adult spinal cord. So this question keep coming all the time. What about the subcostal plane? As you are focusing upon, say, subcostal plane, subcostal, costa means the cartilage, rib basically. So there is a costal margin, the 10th rib, below the 10th rib basically. So this is, if you are marking the costal margin, let me choose some color, say let us take this color. This is the ribs making costal margin on right side and left side. So these are the ribs which are making costal margin. Ribs will be 10th rib, the lowermost, 9th, 8th, 7th. Below that 10th rib on either side, you are putting a line, and that is subcostal plane because it is below the ribs. Now subcostal plane, which is below the costal margin, below the 10th rib, is at which vertebra level? That is the upper border of L3 vertebra. Upper border of L3 vertebra. Came as a question to you. Just you have to memorize this information. You can use this information to derive one more fact, that between this L3 vertebra and between this L3 vertebra and L4 vertebra, you have umbilicus. So umbilicus lies in the anterior abdominal wall, but posteriorly at the level of, umbilicus lies in the anterior abdominal wall, but posteriorly at which vertebra level? L3, L4 vertebra level. And that is where you do lumbar puncture. You want to aspirate the CSF. You have a needle going from posterior. And where will you push the needle to aspirate the CSF or give lumbar puncture anesthesia? L3, L4 vertebra as given by Harrison medicine. Though lumbar puncture can also be done between L4, L5 vertebra. But Harrison medicine says you do it at between the disc of L3, L4 vertebra. So what is the importance here? First of all, umbilicus is on the anterior abdominal wall at vertebral level L3, 4. That is where you do lumbar puncture. And upper border of L3 vertebra, you have subcostal plane lying below the costal margin, below the 10th rib. One more thing, they can ask you, what is the dermatome of umbilicus? Skin root value. What is the root value of skin at umbilicus? Then you say T10 root value. It is important because pain of appendix is referred periumbilical. So periumbilical pain, which is in the skin, referred pain in the skin, is the root value of appendix, vermiform appendix, appendicitis. So appendicitis pain can be felt periumbilical because the root value of our appendix, the nerve carrying pain of appendix, has a root value of T10. So it gets referred to the skin T10, which is umbilicus. Now one more plane is to be remembered. You see this is hip bone. On the hip bone you have iliac crest. You feel the iliac crest and come anterior, there will be tubercle on the hip bone. So there is, let me change the color now, let us use some other color. There is a tubercle on the iliac crest. This is the iliac crest, and on the iliac crest you will have a tubercle. Feel the tubercle and put a line. That is called transtubercular plane. So this is the transtubercular plane, which is basically connecting the tubercle on hip bone, either right hip bone and left hip bone. Connecting the two transtubercular plane is L5 vertebra upper border. L5 vertebra upper border. So eventually what we wanted to learn was simple. L1 lower border, the transpyloric plane. L3 upper border, the subcostal plane. L5 upper border, the transtubercular plane. Maybe that was the only thing which I wanted to convey here, but additionally we have learnt some more information. And when you say transtubercular plane, which is between L4, L5 vertebra, that is where you can push your needle for lumbar puncture again. In fact, if you read Gray's Anatomy, it will say at the highest point of iliac crest, there is the disc of L3, L4, L5 vertebra. So in Gray's Anatomy it is written, highest point of iliac crest, there will be disc between L4, L5 vertebra. That is where you can push your needle. So I told you, lumbar puncture, mostly you should answer L3, 4, but you can also, if that option is missing, you can say L4, 5. And where is L4, 5? How will you decide where is L4, 5? Go to the highest point of iliac crest, put a line, and that line is indicating where you should put your needle according to Gray's Anatomy for lumbar puncture. But anyway, here what you need to remember is L1 lower border, L3 upper border, and L5 upper border. Now take it from me, in different books there may be different values. These are the planes which you are supposed to remember, transtubercular. This is transpyloric, subcostal, and transtubercular. In different books there may be different values. Don't follow them because it is controversy. Follow this information which I have given to you. Now with that, let me just look at the chart. L3, 4 is greater than L4, 5, yes. L3, 4 is best, yes. T10 is the dermatome, yes. Murphy sign, acute cholecystitis, mostly image based questions in anatomy. Yeah, that is correct. Most of the time they are giving you image based questions, giving you image and giving a plane, asking you which plane is that, or cadavers, or histology pictures, or radiology pictures. So image based questions are coming very frequently, yes. Okay, right. So as such, I think we are done with the abdomen region. We should move further now and talk about this case, which is again frequently being asked, rupture of urethra. And rupture of urethra could be posterior urethra or anterior urethra. If it is posterior urethra, then it is rupture of membranous urethra. and if it is anterior urethra, then it is rupture of bulbous spongy urethra. At the moment, what we do is we take a sagittal section in the pelvis region and talk about the male urethra, because mostly the urethra ruptures are happening in male clinically, and discuss the parts of the urethra. Then we can come to this particular diagram. So as we draw this diagram ourselves, what we are looking at is a sagittal section of the male pelvis, and you can start by mentioning this is the apex of urinary bladder. This is the apex of urinary bladder looking anterior. For orientation, this is the apex of urinary bladder which is looking anterior, because you are looking from this side, apex of urinary bladder looking anterior. Urine in the urinary bladder will be pushed into urethra, and we are talking about male urethra here. So this is the male urethra having certain parts. As the urine passes through urethra, the urethra itself is passing through what is called as, say, prostate. So this is going to be the prostate, and passing through prostate is prostatic urethra. So the urethra which passes through prostate is prostatic urethra. Now the urethra will be passing through what is called as the deep perineal pouch, which we can draw here. This is the deep perineal pouch, and the urethra which passes through deep perineal pouch is called as membranous urethra. After it passes through membranous urethra, it is reaching the floor of deep perineal pouch. At the floor of deep perineal pouch, we will find there is a, let us take this color, there is a perineal membrane. This perineal membrane is lying at the floor of the deep perineal pouch, and it has to puncture the perineal membrane, then it will enter the superficial perineal pouch. So as we continue with this urethra, which was in the prostate, prostatic urethra, passing deep perineal pouch, membranous urethra, punctures the perineal membrane at the floor of deep perineal pouch to become spongy urethra. Here you can write the name, say, spongy urethra. Where do you find the spongy urethra? In the superficial perineal pouch. So this is superficial perineal pouch where you have the spongy urethra. This superficial perineal pouch is having a roof of perineal membrane, which itself is floor of deep perineal pouch. So whatever is the floor of deep perineal pouch is the roof of superficial perineal pouch. What is at the floor of superficial perineal pouch? If you talk like that, you can mention, let us use some other color. It is called as the Colles fascia. So what is Colles fascia? Colles fascia is at the floor of superficial perineal pouch. So superficial perineal pouch, what is the content? Spongy urethra. Superficial perineal pouch, what is the roof? The perineal membrane. What is the floor? The Colles fascia. Now this spongy urethra has two parts, a short and a long. The short which you look at here is called as bulbous spongy urethra, and then there is a longer part of spongy urethra which enters the penile shaft, and you call it as penile spongy urethra. So spongy urethra has two parts. In the superficial perineal pouch you will have bulbous spongy urethra, and in the penile shaft you will have penile spongy urethra, and the urine will go out from this external urethral meatus. So there was urine in the urinary bladder. Urine passes through prostatic urethra, then membranous urethra, then bulbous spongy urethra, and then penile spongy urethra, and comes out of external urethral meatus. Now problem is sometimes there can be rupture of urethra. If it is rupture of urethra, let us make use of some distinct color. Let us say, let us use this one, yellow color. Now there can be problem, rupture of bulbous spongy urethra, which can be straddle injury, rupture of bulbous spongy urethra. It is rupture of anterior urethra, or there could be a pelvic fracture leading to rupture of posterior urethra, which could be membranous urethra at the junction of prostate and membranous urethra. So, two cases. Case number 1, straddle injury, rupture of bulbous spongy urethra, which is rupture of anterior urethra, and case number 2, pelvic fracture and rupture of membranous urethra at the junction of prostate and membranous urethra. So, posterior urethra rupture, anterior urethra rupture. How do you decide the boundary line? That boundary line is perineal membrane. And it is understood that if there is a rupture of membranous urethra, which I am mentioning, if there is a rupture of membranous urethra, it is posterior urethra, then there will be mostly mention of pelvic fracture. So, associated pelvic fracture, and this urine will be extravasated, spread around the prostate, around the urinary bladder, around the prostate, around the urinary bladder, which is called perivesical space. Perivesical space. But this urine can also enter the deep perineal pouch. It can also enter the deep perineal pouch. So, you see this urine is going here around the urinary bladder. It is entering the deep perineal pouch, but this urine rarely will enter superficial perineal pouch. Why this urine, when there is a rupture of the membranous urethra, cannot enter the superficial perineal pouch? Because it is prevented by perineal membrane. This perineal membrane do not allow the urine to enter superficial perineal pouch until there was actually associated rupture of perineal membrane. So, it may happen that some drops of urine may come to superficial pouch, but for that the examiner will mention associated rupture of perineal membrane, which does not happen usually. So, in a case of posterior urethra rupture or rupture of membranous urethra, which usually is associated with pelvic fracture, urine will restrict itself perivesical space and deep perineal pouch. What about the other case? Rupture of bulbous spongy urethra, straddle injury. In that case, you will find urine is in the superficial perineal pouch and then moving into penile shaft. It can also move into scrotal area. Not only scrotal area, it can also move into anterior abdominal wall. So, we will focus upon that also, but before we move on to this description, let us first have a look over the diagram which we started with. Rupture of membranous urethra, where all the urine is going. So, this is the diagram we already have talked about. Sagittal section of male pelvis, and this is the urine which is extravasated. Problem was there was a rupture of membranous urethra. Now, this rupture of membranous urethra, as you see, is at the junction of membranoprostatic urethra, and this urine will be in the perivesical space. This urine cannot enter the peritoneal cavity because peritoneum is intact. This urine cannot go intraperitoneal. It will remain subperitoneal. So, this is rupture of membranous urethra at the junction of prostatomembranous urethra. Urine is perivesical space but is subperitoneal. Cannot go intraperitoneal because peritoneum is intact. Cannot go to superficial pouch also. Why? Because prevented by perineal membrane. It may enter the deep perineal pouch where you have what is called as urogenital diaphragm. Urogenital diaphragm is inside the deep perineal pouch. Urogenital diaphragm, which you see here, is inside the deep perineal pouch. So, there might be some muscles making urogenital diaphragm, and around that there can be some urine in a case of rupture of membranous urethra. So, rupture of membranous urethra, urine can be in the deep pouch. Why it is not coming to superficial perineal pouch? Because it is prevented by the perineal membrane. Now, what about the other case where we have straddle injury and rupture of bulbous spongy urethra? If we have a case of straddle injury and rupture of bulbous spongy urethra, then where is the urine? As we mentioned, bulbous spongy is a short part of spongy urethra, longer is the penile spongy. And if urine is in the superficial perineal pouch, which you see here, superficial perineal pouch, it was also moving into the scrotal layers. And not only scrotal layers, it is also moving into penile layers. And not only penile layers, it is also moving into anterior abdominal wall, passing in front of pubic bone. Now, why this urine is spilling extravasation at all these places? Because of a simple fact that there is this fascia, the Scarpa's fascia on the anterior abdominal wall. On the anterior abdominal wall, you have Scarpa's fascia, and that Scarpa's fascia is continuous with penile fascia. And that penile fascia is continuous with the scrotal fascia. And scrotal fascia is continuous with the Colles fascia. And Colles fascia is continuous with the perineal membrane, creating a common space. I'll repeat again. There is Scarpa's fascia, which is the membranous layer of fascia on the anterior abdominal wall. So there is this fascia on the anterior abdominal wall, Scarpa's fascia, and that Scarpa's fascia is continuous with penile fascia. Penile fascia continues with scrotal fascia, which is also called as Dartos fascia. From the scrotal fascia, it is continuous with Colles fascia. Colles fascia is the floor of superficial perineal pouch. Colles fascia is continuous with perineal membrane, and this is an enclosed space urine can spill all around. Where? In the superficial perineal pouch, in the scrotal layer, in the penile layer, in the anterior abdominal wall, and also little bit into the thigh. This is some additional information. Can this urine enter the thigh? Yes, little bit. And why it cannot enter throughout the thigh? Because prevented by fascia lata. Fascia lata. So this urine can definitely enter thigh, but few drops. Cannot enter entire thigh. Why? Because prevented by fascia lata, the deep fascia of thigh. So deep fascia of thigh, fascia lata do not allow this urine to enter into thigh. Why this urine do not enter the deep perineal pouch? It cannot enter the deep perineal pouch because prevented by perineal membrane. Perineal membrane do not allow this urine to enter the deep perineal pouch. And this urine cannot enter the ischiorectal fossa posteriorly, prevented by Colles fascia. So Colles fascia do not allow this urine to enter into ischiorectal fossa. I'll repeat again. This urine cannot enter into deep perineal pouch, prevented by perineal membrane, floor of deep perineal pouch, roof of superficial perineal pouch, and Colles fascia is preventing this urine to enter from ischiorectal fossa. And in the thigh there is fascia lata. Fascia lata will not allow much urine into thigh. Little bit urine can move, but not much of urine can move into thigh, prevented by fascia lata. So these are latest questions and very high chance of getting repeated. Now in the region, a question comes. In the pelvis region, a question comes. Where is this gonadal artery coming from? Gonadal could be your ovarian artery or maybe testicular artery. Let me just go through the chat as well. Yes, in urethra ruptures, they will keep giving you details like blood at the tip of the penile meatus, inability to evacuate the urine, fullness of urinary bladder. All that is clinical history. Okay, and now, why would it enter axilla? See, this extravasation of urine can reach only in the anterior abdominal wall, and where you have the Scarpa's fascia, that is below umbilicus, It cannot move into axilla. One of the student is asking, extravasation of urine, can it enter the axilla? No. First of all, you don't have that much of urine that it continue moving up like that. Plus, simple, the Scarpa's fascia is below the infraumbilical. So urine will be only in the anterior abdominal wall, infraumbilical. It will not come to very high in the abdomen and not at all towards the axilla. Narrowest and widest part of urethra. Narrowest part of urethra is external urethral meatus, where urine comes out of the penile tip. Narrowest part of the urethra is penile external urethral meatus. The second narrowest is membranous urethra. So, if they ask you narrowest part of male urethra, external urethral meatus. If not in the option, then go for second narrowest, which is the membranous urethra. And widest part of male urethra? Widest part of male urethra is bulbous spongy urethra. Bulbous spongy urethra. So, bulbous spongy urethra is widest part of male urethra. If it is not in the option, second widest. And who is the second widest? The prostatic urethra. So, prostatic urethra is also wide, but second widest. So, which is the narrowest? External urethral meatus. Which is the second narrowest? Membranous urethra. Which is the widest part of male urethra? Bulbous spongy. And which is the second widest part of male urethra? The prostatic urethra. In which kind of trauma membranous urethra is ruptured? Membranous urethra is ruptured if it is pelvic fracture. They are commonly associated. Okay, so let us just continue with the question. We had this question which was asking us about the gonadal artery, and gonadal artery could be, the ovarian artery if it is a female, and testicular artery if it is a male. Remember, testicular artery or ovarian artery, which is called gonadal artery, are anterolateral branches of abdominal aorta. Abdominal aorta. Now, we will think that the ovaries are in the pelvis and the branches are coming from the abdominal aorta. Why? Because ovaries or testes, they start developing in the abdomen. So, gonads develop in the abdomen, later they descend down, carrying the arteries down. The arteries become long. Which arteries become long? Gonadal arteries become long. Since the gonads develop in the abdomen, later descend down, their branches are coming from abdominal aorta, may it be the ovarian artery or testicular artery. Now, ovarian artery, which is shown here, anterolateral branch of abdominal aorta, is not only supplying ovary, it is supplying uterine tube also. And not only it is supplying uterine tube, it is also supplying the uterus. It has anastomosis with the uterine artery. So, as it has anastomosis with the uterine artery, it will supply the uterus also. Where is uterine artery coming from? Uterine artery itself is coming from the artery of the pelvis. And which is the artery of the pelvis? You see, abdominal aorta bifurcate into common iliac artery, and common iliac artery give you internal iliac artery, and it is the internal iliac artery which will give us the ovarian, the uterine artery. I will repeat. Abdominal aorta bifurcate into common iliac give internal iliac. Internal iliac artery is, as I can show here, abdominal aorta giving the common iliac, giving internal iliac, giving the uterine artery. So, uterine artery is supplying the uterus and is anastomosing with the ovarian artery. Ovarian artery itself is a branch of abdominal aorta. This is called collateral circulation, double supply to uterus. Now, the problem is, there was a lady who gave birth to a baby and there was a postpartum hemorrhage. You wanted to stop the postpartum hemorrhage, but somehow all your methods are not working. So, eventually you decide for devascularization, and for devascularization question has come. If you want to stop the postpartum hemorrhage and going for devascularization, which arteries are you going to ligate? The very first artery I will ligate is, of course, the uterine artery, because uterus is bleeding. So, I will stop the bleeding, try to stop the bleeding by blocking uterine artery. And what if it is still bleeding? Which is the next artery you will block? If blocking the uterine artery is not working, then I will block the ovarian artery also. And what if it is still bleeding? Then there are other arteries also supplying uterus, like vaginal artery is, vesical artery is. So, instead of going for those arteries, I just block the anterior division of internal iliac artery. Anterior division of internal iliac artery. But I should not include posterior division. and that is one important topic which we will draw and discuss. The point is, there was a lady who gave birth to a baby, and after birth there was some bleeding from the uterus, postpartum hemorrhage. You tried methods, uterotonic, manual massage and all those things did not help. So you go for devascularization. The first artery you block is uterine, second you block is ovarian, third you block is anterior division of internal iliac artery. That kind of questions came already for your FMGE exam, and take it from me, they'll keep coming. So what information we want to collect here? First of all, you should know the branches of the internal iliac artery in the pelvis, because again they are questions. So let us talk about that. Once again, I'll tell you, this is abdominal aorta bifurcating into, this is abdominal aorta bifurcating into common iliac artery. And let us focus upon right side, right hip bone, right side. So right-sided common iliac artery, though whatever is happening on right will happen on left also, symmetrically, congruent arrangement. But let us focus on one side, say right side, right common iliac. It is called common iliac because it gives two branches, external, internal iliac. We are not concerned with external iliac, but we are concerned with internal iliac because internal iliac will supply the pelvic viscera. Pelvic viscera are more anteriorly urinary bladder, behind that uterus, behind that rectum. So if you talk about, say you are looking from side view, urinary bladder, uterus and rectum, most anterior urinary bladder, then uterus, then rectum. So three pelvic viscera, three arteries, and simply called. The internal iliac artery will give you branches to the three pelvic viscera, simply called urinary bladder, vesical artery, uterus, uterine artery, rectum, rectal artery. So internal iliac artery is giving us branches to the three pelvic viscera, which we will draw ourselves. But here, as you look at this diagram, it appears complicated. So let us draw our own diagram. We'll do it ourselves. And as we are doing it ourselves, say we are looking at the abdominal aorta here, and this abdominal aorta is bifurcating. So on both sides, right and left, we call them as common iliac artery. Common iliac is called common because it further bifurcates into two. So it will give us what is called as the external iliac artery and the internal iliac artery. Let us just zoom this a little bit more. So as we see, abdominal aorta bifurcating into the common iliac artery on right left side. We are focusing on the right side. So common iliac dividing into external iliac, internal iliac. Internal iliac itself divides into two, giving us anterior division and posterior division. Now if you remember the branches from the posterior division, which are only three, rest all the arteries are coming from anterior division. So there are a lot of branches coming from anterior division and few branches coming from posterior division. We can remember the three branches which come from posterior division. If you know the three branches from posterior division, rest all other than that should come from anterior division. So then what are the three branches from the posterior division of internal iliac artery? The branches from the posterior division of internal iliac artery can be remembered by a mnemonic: SIL branches. SIL branches, very important. In the recent coming exams, it has become quite important. So if you say posterior division of internal iliac artery is giving SIL branches, what is S for? S is the superior gluteal artery supplying the gluteal region, especially the sciatic nerve. If you compromise superior gluteal artery, you compromise sciatic nerve, gluteal pain. So posterior division giving us SIL branches, S is superior gluteal artery supplying gluteal region, especially the sciatic nerve. Arterial supply to sciatic nerve is this artery majorly. What is I for? Iliolumbar artery. It is iliolumbar artery. And what is this L for lateral sacral artery. Lateral sacral artery. So just remember cell branches. S for superior gluteal artery, I for iliolumbar artery, L for lateral sacral artery. Now whatever names you get must all come from anterior division, like we just mentioned. There will be some arteries, like let us name them now, supplying the pelvic viscera. So which arteries were supplying the pelvic viscera? Urinary bladder, vesical artery; uterus, uterine artery; rectum, the rectal artery. So you mean to say vesical artery or uterine artery or rectal artery would come from the anterior division? Yes, of course. And vesical arteries are superior vesical artery, inferior vesical artery. Superior vesical artery, inferior vesical artery. Inferior vesical artery in female is called vaginal artery. So in male it will be superior vesicle, inferior vesicle. In female, inferior vesicle is called as vaginal artery. So vaginal artery or uterine artery or rectal artery, they are all branches of anterior division. Anterior division not only supply the 3 pelvic viscera, it also supply 3 regions: the gluteal region, medial thigh and perineum. To supply the 3 regions, they'll give 3 arteries. So 3 branches to pelvic viscera and 3 regional arteries. What 3 regional arteries coming from anterior division? Supplying the gluteal region. You mean to say gluteal artery? Yes. But then already we got one gluteal artery which came from posterior division. Name of that was superior gluteal. So name of this will become inferior gluteal. Already we got superior gluteal artery from posterior division of internal iliac artery. So this must be inferior gluteal artery, additional supply to gluteal region. And what other arteries coming from anterior division? Let me zoom this a little bit more. As we continue talking about 6 branches from anterior division, 3 already given to pelvic viscera, 3 to regional arteries. Inferior gluteal artery, what is the other one? Medial thigh. Name? Obturator artery. Obturator artery for medial thigh. And pudendal artery to supply perineum. So pudendal artery supplying perineum? Yes. Obturator artery supplying medial thigh? Yes. Inferior gluteal artery, they are all coming from anterior division? Right. So instead of remembering what all is coming from anterior division, I will just remember what is coming from posterior division, the cell branches. And if in the option cell branches other than that any name is given, I can simply blindly can mention must have come from anterior division. Now what about that case? Lady delivered a baby, postpartum hemorrhage, you were blocking some arteries, like you were blocking one artery, name was, first of all you blocked the uterine artery, but it did not work. Let us take some other color. You blocked the uterine artery, did not work. Next in sequence was ovarian artery, but still the bleeding was going on. Third was block the anterior division of internal iliac artery. So I'll repeat, for postpartum hemorrhage, which is the first artery you block? Uterine artery. What is the second artery you block? The ovarian artery. What is the third artery you block? Ovarian artery, branch of abdominal aorta, if you remember. What is the third artery you block? Anterior division of internal iliac artery. Why do you block the anterior division? Why don't you just block the internal iliac artery itself? I won't do that. Why? Because if I block the internal iliac artery, then I am precipitating gluteal ischemia, ischemia of sciatic nerve, which I should not. So instead of blocking internal iliac artery, I'll let the internal iliac artery give the posterior division. Beyond that, I'll put the block. And this can be seen in the next diagram. So it is the case here, and the case was this lady who had postpartum hemorrhage. You are focusing on right side. Of course, you have to do it on the left side also. But as you continue, you will notice that here in this diagram, we are telling this is common iliac artery, and common iliac artery has now divided into external iliac artery, and it has given us the internal iliac artery also. So this is the internal iliac artery. Where would you put your artery forceps? You are not supposed to put your artery forceps on internal iliac artery. Let the internal iliac artery divide into two divisions, which is, say, here, posterior division, and then you can also mark the, use the white color itself, anterior division. So the point is, where should you block? Where is this artery forceps going? You are blocking it here, anterior division of internal iliac artery, so that you are basically blocking uterine artery, vaginal artery, vesical artery, everything. But you are leaving the posterior division there, so that you continue supplying the cell branches. And what is cell branches? Cell branches we already have mentioned. Let us take this color. What is S? The superior gluteal artery. What is I? Iliolumbar artery. And what is L? Lateral sacral artery. So S, I, L branches. Posterior division gives cell branches, superior gluteal artery, sciatic nerve is already supplied now, iliolumbar and lateral sacral. Let them be given, and beyond that you have to block the anterior division of internal iliac artery. Now I have gone too much into detail, but I am expecting that these questions, at least branches of iliac artery, will persistently keep coming to you, and you should be ready with that. Going on to some details of lower limb now, and before I move on to this region, gluteal region, let us just go through the chart. Atonic PPH, yes. Okay. Right. So let us just continue, because already we have spent 1.5 hours here. So let us see some details of lower limb as well. Very frequently asked questions on the gluteal region. Three muscles in the gluteal region: the largest, gluteus maximus, the most posterior and largest. If you remove it, a little bit anterior and deeper to gluteus maximus is gluteus medius, and little bit deeper and anterior to that will be gluteus minimus. So three gluteal muscles: most posterior, a bit anterior, the most anterior, maximus, medius and minimus. And maximus is inserted on femur bone posteriorly. There is a gluteal tuberosity, that is the insertion. So gluteus maximus insertion is gluteal tuberosity on the posterior surface of bone femur. If you say gluteus medius, it is inserted on lateral surface of the bone femur, greater trochanter. So lateral surface of greater trochanter is the insertion of gluteus medius, and the minimus, which I told more anterior, is attaching to greater trochanter on the bone femur, but more anteriorly. Point is, one is a posterior muscle attaching to femur posteriorly, one is a middle muscle, medius, attaching to lateral surface of greater trochanter on bone femur, and one is most anterior among the three, so attaching anterior surface of greater trochanter on the bone femur, and this is all going to work upon bone femur. As is evident, this muscle, gluteus maximus, can pull the femur posterior because it is attaching to bone femur posterior, and if you pull the femur posterior, it is a muscle of hip extension. Gluteus maximus is the muscle of hip extension, whereas the gluteus medius and minimus, if you focus upon them, they are the muscles of abduction, hip abduction. They can pull the femur away from the body. If you pull the femur away from body, it is called abduction. And not only they are abductors at the hip joint, they also do medial rotation. Means they can rotate the femur medial towards the midline. So these muscles, that is gluteus medius and minimus, they are not only abductors of the femur doing abduction at hip joint, they can also rotate the femur medially, medial rotation. Now if these are medial rotation, which muscles are lateral rotators. You cut the gluteus maximus, deep to that you will find some short lateral rotators. Short lateral rotators. Like which muscle? If you cut the gluteus maximus, deep to that you can have some short lateral rotators like piriformis. There is a muscle called piriformis, and there are some muscles like quadratus femoris. A quadrangular muscle attaching to femur, quadratus femoris. So piriformis, quadratus femoris, where do you find these muscles? If you cut the gluteus maximus, under cover of that, you have piriformis, quadratus femoris, and their lateral rotators. You mean to say these muscles are going to contradict the activity of gluteus medius and minimus? Yes, because gluteus medius minimus, they are medial rotators. They will be antagonized by the short lateral rotators, piriformis and quadratus femoris. Even gluteus maximus is a lateral rotator, partly. Are you telling that gluteus maximus is also going to antagonize gluteus medius and minimus doing lateral rotation? Yes, it can do lateral rotation of the femur. It can rotate the femur laterally, antagonizing. So gluteus maximus, by doing lateral rotation, can antagonize the medius and minimus. Once you have that kind of orientation, you should also know gluteus medius and minimus, especially medius, is important for one more function. They have already done abduction and medial rotation. There is one more function. Plus, you should know these muscles, these two muscles, are supplied by a nerve called superior gluteal nerve, and gluteus maximus is supplied by inferior gluteal nerve. So there is an inferior gluteal nerve which will supply gluteus maximus. Inferior gluteal nerve will supply gluteus maximus, whereas superior gluteal nerve will supply gluteus medius and minimus. So what is the function of superior gluteal nerve? Function of superior gluteal nerve is, of course, abduction and medial rotation. And what is the function of inferior gluteal nerve? Inferior gluteal nerve is hip extension, and not only hip extension but also lateral rotation at the hip joint. So like that you can memorize the details. Now, as I am suggesting, if you have cut the large muscle, name is the gluteus maximus. If you have cut the large muscle, say this is posterior view right hip joint, right gluteal region, posterior view right gluteal region, you have cut the large muscle, name gluteus maximus. This is gluteus maximus which you have already cut. As you can see, this is the muscle which was inserting here on the posterior femur. We were telling gluteal tuberosity, it can pull the femur posterior, causing hip extension. So you have cut the gluteus maximus which was inserted on the upper femur posteriorly at gluteal tuberosity, doing hip extension supplied by inferior gluteal nerve. You remove it. So what do you see deep to that? Deeper and more anterior, it was the gluteus medius. This muscle is gluteus medius which was deeper and a bit more anterior. And if you remove that also, deeper and more anterior to that was the inferior gluteal nerve. So let us change the color. This is gluteus minimus. This is now the muscle gluteus minimus. And if you still keep going more anterior, there is a muscle called tensor fascia lata. Now why we are focusing upon this tensor fascia lata also, let us take this color, tensor fascia lata, because tensor fascia lata along with gluteus medius minimus, they are supplied by this nerve which we are calling as superior gluteal nerve. So this is superior gluteal nerve. This is the superior gluteal nerve supplying three muscles. So what is the three muscles supplied by superior gluteal nerve? Superior gluteal nerve supply three muscles, namely gluteus medius, minimus and tensor fascia lata. And what is the function of gluteus medius, minimus and tensor fascia lata? Three functions. What are the three functions? Two we already have mentioned, the abduction, medial rotation, and third is stabilize the pelvis while walking. I'll repeat once more. Gluteus medius, minimus and tensor fascia lata are three muscles supplied by one nerve named superior gluteal nerve. They have three functions. What are the three functions of the three muscles? These three muscles, the three functions are: number 1, abduction at hip joint; number 2, medial rotation at hip joint; number 3, stabilize the pelvis while walking. If they are not working, if there is injury of superior gluteal nerve, you will have Trendelenburg test positive and the pelvis to the opposite side. Means if there is injury of right-sided superior gluteal nerve, pelvis on the opposite side keep falling down. Trendelenburg test become positive on the right side. Right Trendelenburg test positive because right-sided muscles are not working. I'll repeat again. Maybe right-sided superior gluteal nerve is compromised. Right-sided glutei medius, minimus, tensor facial are not working. They are unable to stabilize the pelvis while walking. Then Trendelenburg test become positive on right side. You ask the patient to stand on right foot, take the left foot in the air. Ask the patient to stand on right foot, take the left foot into air, and you find that pelvis drops down on the left side. So if the pelvis is dropping on the left side, problem is actually on the right side. Right gluteal muscles are unable to prevent that fall. That fall is because of gravity. They are unable to contract the gravity. Gravity will pull the pelvis down. Normally, it cannot. It is balanced by these muscles. So, right-sided superior gluteal nerve injury, right-sided gluteal muscles paralyzed. You ask the patient to stand on right side and you find that left pelvis drops down pulled by gravity. This is called Trendelenburg test positive on right side. Be careful about the terminology. I am not going to details of Trendelenburg test here, but these gluteal muscles are medial rotators. Which muscles are lateral rotators? Lateral rotators are deep to gluteus maximus. Yeah, name. Lateral rotators are piriformis muscle, which is, we can show here. This is some color which is little bit different. Piriformis and quadratus femoris. Quadratus femoris. So piriformis muscle and quadratus femoris muscle, what are they doing? Lateral rotators. Short lateral rotators. Antagonizing the gluteus medius and minimus because they were medial rotator. So what are the three lateral rotators? They are piriformis, quadratus femoris and gluteus maximus. What is gluteus maximus supplied by? Gluteus maximus is supplied by this nerve which is below piriformis, and name that will be inferior gluteal nerve. So piriformis is a key muscle. Above that is superior gluteal nerve. Below that is inferior gluteal nerve. Inferior gluteal nerve supply the large muscle gluteus maximus for hip extension and lateral rotation, whereas superior gluteal nerve supply the three muscles gluteus medius, minimus, tensor facial lata for three actions, namely abduction, medial rotation and stabilize the pelvis while walking. So these are some of the things which we should remember. What about the sciatic nerve now? As you see, sciatic nerve is coming below piriformis and it will have two parts. Sciatic nerve is coming below piriformis in the gluteal region and will have two parts. It will have a tibial nerve going with the tibia bone and the fibular nerve going with the fibula bone. The fibular nerve is also called as peroneal nerve. So sciatic nerve will divide into two, one going with tibia, tibial nerve, one going with fibula, fibular nerve, and fibular nerve is also called peroneal nerve. Actually it is called as common peroneal nerve. Why it will call as common peroneal? Because it again divides into two. So here we are telling, first of all, say let me put it separately. This is, we are talking about say sciatic nerve. So if we are talking about the sciatic nerve, so this is the sciatic nerve. The sciatic nerve is dividing into two. And what are the two names? Tibial nerve going with the bone tibia, and the other one, common peroneal nerve. Why it is called common peroneal nerve? Because it further divides into two. So what are the two branches of common peroneal nerve? One which goes lateral is superficial peroneal nerve, and one which goes medial is deep peroneal nerve. Sometimes the superficial peroneal nerve can be damaged, and there can be questions upon that. So sciatic nerve going to divide into tibial nerve and peroneal nerve. Peroneal nerve itself is called common peroneal nerve. This is the common peroneal nerve, and common peroneal nerve common because further divides into two. The deep peroneal nerve and superficial peroneal nerve. The superficial peroneal nerve is also called superficial fibular nerve, and superficial fibular nerve is related to the neck of the fibula, and neck of the fibula, it might be damaged if there is injury to the superficial peroneal nerve, or actually the nerve which relates with the neck of fibula is common peroneal nerve. So if there is injury to common peroneal nerve, obviously there is injury to superficial peroneal nerve. Overall, what will the problem? That's what we want to see. Let me use a diagram to discuss the same. Here is front view now. Front view of right lower limb, basically right leg region. Since it is a front view, we can mention here, say, there was a sciatic nerve, but sciatic nerve runs in the posterior thigh, and it gave tibial nerve with tibia and gave the fibular nerve with fibula. It all will happen posteriorly, but since we are looking from the front view, now this sciatic nerve, tibial nerve, we are not focusing upon. We are focusing upon common peroneal. Common peroneal has come lateral to the neck of fibula, where it can be damaged, and if it is damaged, then there will be a problem with superficial peroneal nerve and problem with deep peroneal nerve also. So superficial peroneal nerve which goes lateral, deep peroneal nerve which goes anterior. I'll repeat. Sciatic nerve gave two branches, tibia, tibial nerve, fibula, fibular nerve, also called common fibular nerve, also called common peroneal nerve. Going lateral to neck of fibula, it was damaged. Say there was a lathi charge, police lathi charge. When there is a police lathi charge, police people are trained to hit people where? Can hit at any place, but should not hit at on the head actually. No, don't hit on the head, don't hit in the below belt. Then where do I hit? I have a lathi, and a lot of people are standing in front of one prominent politician house. There's a house, this politician is very prominent, like Rahul Gandhi. People are standing in front of gate of Rahul Gandhi, and you don't want them to stand, you just want them to lie on the ground. Send some police people will hit like this. Where do they hit? Here, lathi charge, police lathi charge, they hit below the knee. You were shouting like this, now you are hit below the knee, now you lie down on the ground and then you shout from there. What happened? Lathi charge, police lathi charge, this lateral to the neck of fibula, this nerve is damaged. So what is the problem? Problem is, if you say deep peroneal nerve, it is also called as anterior tibial nerve because it is going anterior to tibia. It supplies dorsiflexors of the foot, extensors of the foot at ankle joint. So anterior tibial nerve or deep peroneal nerve supply dorsiflexors or extensors of the foot at the ankle joint. But if the nerve is damaged here, then the patient cannot dorsiflex, there will be a foot drop. There will be a foot drop. And when there is a foot drop, you cannot keep standing on the ground, you will fall on the ground. From the ground only you can do high or whatever you want to do. But you cannot keep standing, you will fall down. That is the purpose of police people. Just fall down and then you do whatever you do. Don't climb upon the gate. Don't climb upon the gate and enter the house. Stay outside. So that is why they are trained like that. So deep peroneal nerve, other name is anterior tibial nerve. You see, can you see, let me zoom this. This patient, you find is having a foot drop. Dorsiflexors are gone because anterotibal nerve is gone. What is the other problem? Other problem is, as you see here, this nerve, which is the other one, let us use the other color. Superficial peroneal nerve is supplying the muscles of eversion, everters, like peroneus longus, peroneus brevis. So even they will be compromised. The superficial peroneal nerve is nerve of lateral leg compartment, and in the lateral leg compartment you have peroneus longus, brevis. Peroneus longus and brevis, they turn the sole lateral, which is foot eversion. So there will be loss of foot eversion also. Not only there is loss of foot eversion and loss of foot dorsiflexion, there is sensory loss also. Most of the dorsum of the foot is supplied by the superficial peroneal nerve, except the dorsum of the first web space on the foot, which is supplied by deep peroneal nerve, L5 dermatome. So if there is a lathi charge, police lathi charge, what all problems will be there? Number 1, foot drop, and number 2, the loss of foot eversion, and number 3, there will be sensory loss on most of the dorsum of the foot, because most of the dorsum of the foot is supplied by superficial peroneal nerve, it is gone, and dorsum of the first web space on the foot, deep peroneal nerve is gone, L5 dermatome. These are some of the questions which come to you. Now, one other topic which they keep asking. You have a case of CABG, coronary artery bypass graft. You want to remove a vein from below, great saphenous vein. And when you were removing the great saphenous vein, you have damaged a nerve. Where is the sensory loss? So a case of coronary artery bypass graft, you wanted to remove great saphenous vein. You have removed the great saphenous vein, but you have damaged one nerve. Where is the sensory loss? You see, related with great saphenous vein is a nerve which is the saphenous nerve. And saphenous nerve is a branch of femoral nerve bearing the dermatome L4. So saphenous nerve, which is running with the great saphenous vein, passing anterior to medial malleus, this is medial malleus, passing anterior to medial malleus is great saphenous vein, still anterior is saphenous nerve. While you were removing the great saphenous vein, you might have damaged a nerve which is running anterior to it, anterior to medial malleus, name is saphenous nerve. Where is the sensory loss? Sensory loss will be L4 dermatome. And where is L4 dermatome? The medial malleus, medial dorsum of the foot, and medial side of the leg. Where is the sensory loss? L4 dermatome. Where is L4 dermatome? Medial side of the dorsum of the foot and medial malleus and medial side of the leg. Be careful, saphenous nerve do not reach the great toe. It do not reach the great toe. And because saphenous nerve do not reach the great toe, there won't be any problem of sensation on the great toe. Why? Which nerve supply great toe? If it is medially, the great toe is supplied by superficial peroneal nerve, and if it is laterally, it was supplied by deep peroneal nerve. A question comes, medial surface of the great toe is supplied by, you say, deep peroneal nerve. Superficial peroneal nerve is medial, and lateral surface of great toe, deep peroneal nerve. How will you remember that? You can just go back to this diagram here. If you notice, they are asking you a question. Their question is, say, which nerve supply medial surface of great toe? Superficial peroneal nerve. And which nerve supply lateral surface of great toe? That is the deep peroneal nerve. It is simple to remember. Dorsum of the first web space they are asking. If it is medial, then this all area, that is superficial peroneal nerve. And if it is lateral surface of great toe, then it is deep perineal nerve. But is it supplied by saphenous nerve? No. What is the root value of saphenous nerve? L4. What is the root value of great toe? L5. So will there be any sensory loss on great toe when you remove the great saphenous vein and damage the saphenous nerve? No. There will be no sensory loss on the great toe because saphenous nerve do not have the dermatome L5 or great toe to supply. So that's all I wanted to take care of today. Almost 2 hours now. And let me see if you have any queries. PrepLadder, can we get this PDF? Yes, you will definitely get this PDF. I'll upload it to the cloud. You can download from the cloud. Link will be given as I am seeing multiple times. They are flashing. Join our Telegram. There you will get the PDF. So download the PDF from there. Maybe they have some method of distributing this PDF. You will definitely get it. And okay. Right. So I think that is all I wanted to convey to you, and I am very hopeful, like I said earlier, lot many questions are going to come from the topics we are teaching, at least in anatomy and even the other 18 subjects. Just dedicatedly watch these FMGE marathon series. Okay. How many time to revise the topic? Once you read first time and revise 1, 2 times, total 3 times. First reading and revise once, revise again. Total 2 revisions, minimum. Minimum 2 revisions, and maximum, there is no maximum. You can revise 100 times also, still you will forget. But the minimum, after first reading, you should revise 2 times. And your exam should be within a month. If it is beyond 1 month, revise 1 more time. So if you read today and your exam is after 1 month, then you have to read it 2 more times, total 3 times. You are a good singer as well. How do you know? I used to be a good singer, now there is no time to sing. But you will find my YouTube videos, 1 or 2 videos are there where I am singing. Not only singing, acting also. You just type Dr. Rajesh Kaushal, no anatomy. Just type Dard-e-Dil. Dr. Rajesh Kaushal, Dard-e-Dil. And you will find the video. Watch the video in your free time, not in the time when you are studying. Yes, seen it. Yes, that is great. You already have seen it. Fantastic. Little bit that is, you should have some hobbies as well. Violinist, I am not very sure about violin. I can play violin, but not that good as you have seen in the video, because in videos, you can always manipulate. Anyhow, thanks a lot for giving us the opportunity to be of some help to you people. Just being a guide, you have to work hard, become a good doctor, a good human as such in entirety. Humanity is supreme. That is what we always should struggle for. Okay, thanks a lot. Take care. All the best for your exams, and see you soon.
Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon.